My name is Kelly Rygrock, and I'm a PA and the coordinator for the vascular anomalies team at UT Health Houston in Texas. At this point, we've all seen the benefits that alpelisib can provide some of our vascular anomalies patients, but getting them access to the medication can have its challenges. In 2013, an NIH workshop provided us with clinical criteria with which to diagnose PROS without a confirmed PIK3CA mutation. And then in 2022, when the FDA approved ViJoice for patients with PROS, it also did not require a confirmed PIK3CA mutation. However, insurance companies seem to have their own rules. Unfortunately, each insurance company has created their own criteria for approval of the medication. With a total out-of-pocket cost of over $33,000 a month, we have to go through insurance and follow their rules. The only consistency amongst insurance companies is that they all require a confirmed PIK3CA mutation for initial approval. Knowing this, we now have about 100% approval through insurance at prior authorization request, as long as we have a positive PIK3CA mutation. Unfortunately, that little piece is a whole other big challenge, but we've found success with our current process. We've been bundling obtaining a tissue sample with another procedure, which has helped regarding insurance approval for the biopsy. We of course can get tissue from surgical resections or debulkings, but we've also been obtaining biopsies at the same time as laser treatments or MRI while patients are already under anesthesia. For example, when patients have an MRI under anesthesia in the hospital, I'll go down to the MRI suite and perform a biopsy prior to the patient being woken up from anesthesia. This has helped reduce conflict with parents who don't want to suffer a procedure or round of anesthesia for their young children. We've also found that obtaining an excisional or incisional biopsy rather than a punch biopsy has increased our hit rate. Once we have tissue, we have a specific pathologist who reviews it and sends it out for overgrowth panel. Going through our pathologist has also allowed us to pull tissue from prior surgeries that were done even several years ago to still get positive hits. And finally, we changed the lab that we send out to a lab with better sensitivity, catching variant allele frequencies of 3 to 5% for certain PIK3CA hotspots. Since 2022, we've had 29 PIK3CA and 2 PIK3R1 confirmed gene mutations, which is about 33% of all genetic testing we have run in that time frame. Our negative rate is now less than 30%. The positive hit rate has gradually increased over that time. While we still get a fair number of negatives, we're running more tests, and negative hits as a percentage of our overall genetic testing is decreasing each year. For patients fitting a phenotype but with a negative genetic panel, we've also had some success with repeat biopsy. So even some of these negative results have ended up being positive. We've also been able to track what hotspots carry the mutation, which hopefully will benefit us for future research. So despite how wonderful our clinical expertise to clinically diagnose PROS and identify which patients may benefit from alpelisib, insurance companies still require the confirmed PIK3CA mutation. And while confirming PIK3CA mutations is a challenge, there are certain processes that have helped increase our hit rate. This has allowed our small clinical center to grow into a larger pharmacology practice. Thank you.
Thank you very much. We're open for questions. I assume for colleagues practicing in the US, these are shared frustrations across all states and jurisdictions and cities and hospital institutions.
Congratulations, Kelly. Excellent work on behalf of you and your team. I would encourage you to consider adding one more column that I think this group needs to consider. It's the patient who you can't get approved for genetic testing to get the PIK3CA variant, to get the medication. Same insurance company, just making you go round and round. Any experiences you've had with that? I know I've had it.
Yeah, so by bundling our biopsies with our procedures, I'm not actually getting prior authorization for the genetic testing, and it's being bundled in with the other CPT codes for what we're doing. But we certainly have a challenge getting everything approved and processed. We have patients that we want to put on drug, but it's not always easy just to think that they would benefit.
And it's also going through our pathologist, and we have an agreement with the other pathology department that's running some of the testing for us, so that's why we've been able to do it more often. And it's mainly because we're getting all the approval for everything else ahead of time, including the biopsy.
I think that was a really great talk. I'm Sarah Shepard from NIH. I just wanted to advertise that through my study at the NIH, we can do free clinical testing. I mean, free to your patients if they want to participate. So if you ever need help with anything, please just look us up.
Yeah, thank you. Not a question, just a comment. I'm Megan Bertram from Michigan State. I had a patient who came back with a TEC mutation, and their insurance would absolutely not approve alpelisib under that circumstance. And I took it to the Michigan Insurance Commission, and a geneticist reviewed it and overturned our case. So just helpful to know that states have insurance commissions and you can appeal. Wonderful. Thanks.
Helpful to have a geneticist who understands the pathways to do that and ensures. So. Thank you very much. Great talk. So next we have